welcome everyone to our November Homeless Services Task Force. My name is Christian Horvath. I'm your chair. Thank you all for being here and participating. Let me see if we can figure out a way to do introductions. It's always challenging here. So I guess let's just start with Shari. Just do a quick introduction, and then I'll just call on each of you that are up, and you can just tell us who you are and where you're from.
Gary Weaver, Harbor Interface Services, Director of Programs.
Okay, Lori.
Lori Jacobs with the South Bay City Council of Governments.
Okay, and the other Lori?
Oh, sorry.
That's okay. I was muted, so that was good. I'm Lori Ramey. I'm the Senior Director over Outreach and Street Medicine for MHALA's Homeless Outreach Program, the MDT Public Spaces teams, part of the E6 strategy.
Fantastic. George?
George Chen, Torrance City Council.
Gabriella?
Gabby Medina, Office of Councilmember Joe Buscaino, District Director, and I oversee all the homelessness initiatives in the district.
Lisa?
Lisa Gray, Beach Cities Coordinator, Harbor Interfaith.
Great. Michael? Officer Dyberg.
Oh, sorry. Mike Dyberg, Redondo Beach Police Department. I'm a new sergeant assigned to the Community Services Unit here. This is my first meeting with y'all.
All right. Well,
Welcome.
Congratulations and welcome, sir. Mr. LaRock.
Good afternoon, everybody. John LaRock, City of Redondo Beach.
Okay. China.
Hello, China Gerstner, Homelessness Liaison, representing Caltrans, also working with the Unified Homeless Response Center, led by LA Mayor Eric Garcetti.
Nice to meet you. Jackie?
Jackie Backrack. I'm the Executive Director of the South Bay Cities Council of Governments, and welcome to our meeting.
Nancy?
I'm Nancy Wilcox. I'm with the South Bay Coalition and Homelessness.
All right. Brett?
I'm Brett Feldman. I'm a physician assistant and director of street medicine at USC.
Zulma?
Yay, fight on! Oh.
Good afternoon, everybody. Zulma Gent with the City of Torrance City Manager's Office, Management Associate.
Thank you. George?
George Gabriel, City of Manhattan Beach, Senior Management Analyst, as well as Homelessness Liaison.
Fantastic. Jeannie?
Hi, Jeannie Naughton, City of Rolling Hills Estates.
All right. I don't see a name for this person, so I'm going to skip and I'll go to Jeff Newman. You're muted, sir.
He's having a little trouble hearing us.
Okay.
Yeah.
I'll skip and go to Wayne.
Wayne Windman, Redondo Beach Police Department.
All right. Renee.
Oh, Jeff is coming through my audio. I'm going to let him hear through my Zoom, okay?
Right. Sure thing.
All right, so Renee Corey, family medicine at Harbor-UCLA.
Oh, fantastic. Lori? Now I'm getting to the people that have just names up, so.
I am Lori Jones with the City of Inglewood, Grants Coordinator.
Thank you. Viet?
Good afternoon, everyone. Viet Wong from the City of Torrance.
Okay. Kimberly?
Hi, Kimberly Mack with the City of Hawthorne. I'm the Housing and CDBG Programs Manager.
Fantastic. Trevor?
Hi, I'm Trevor. I'm the Program Manager for the Harbor-UCLA E6 MDT Outreach Team.
Fantastic. Vaughn?
Hello, good afternoon, everyone. My name is Vaughn Norris. I'm the Community Service Manager, Community Service Director for the City of Hawthorne.
Great. Michael?
Hi, this is Michael Reyes, Director of Municipal Services for the City of Wandale.
Great. Erin?
Hi, I'm Erin. I work at the Harbor-UCLA PATH
MDT program as well.
Okay, Amy.
Hi, Amy Giebert with the Office of LA City Council Member Joe Buscaino.
Great. Sarah.
Hi, I'm Sarah Cooper. I'm the Community Engagement Coordinator for Spot 8 at LASA.
And Y Slater. All right. And then the person I missed, now your name, Deborah from Caltrans.
Yeah, good afternoon. Deborah Prochnow, Deputy District Director for Caltrans LA and Ventura.
Thank you for being here. Richard.
Hey there, are you referring to Richard Wise?
I am, sir.
Hey there, sorry about that. Well, hello everyone. I'm sorry I'm getting in late. So Richard Wise, St. Margaret's Center, Client Resources Coordinator, Housing Navigation, Street Outreach.
All right, fantastic. Well, thanks everyone for being here. Lots of new faces, so we appreciate you joining us today, as well as those who are our regulars. We have notes from our September meeting. Unless there are any comments or concerns about those notes, I will just receive and file them. So if you have anything that you want to bring up, please do so now. Seeing none, we'll just receive and file those. Okay, so we're going to move on to our first item here tonight, which is an overview of street medicine, and we have a team here of Brett Feldman, Renee. Let me just see, did I miss anybody else? So Brett and Renee, I guess this is all you guys. Why don't you take it away?
Excellent, thank you. Thank you, Grace. Grace, should I just ask when to advance the slides?
I think that'll work perfectly, yeah.
Okay. So my name is Brett Feldman. I'm a physician assistant and director of street medicine for USC. I'm also the vice chair of the International Street Medicine Institute, which is an international organization that provides technical assistance to about 140 programs around the world. And today I just wanted to give kind of an overview of street medicine and how we do it here at USC. Next slide. So essentially, street medicine is defined as the direct delivery of healthcare to the rough sleeping population. So this is specifically for the unsheltered homeless. The care has to be performed on the street. So it's not done for the unsheltered homeless in a shelter or in a soup kitchen. It's done through walking rounds. In all the places I've been, I've seen it done with motorcycles, horsebacks, kayaks. I'm actually started doing street medicine in Pennsylvania, and there was a camp of all homeless youth that lived along the river, and we could only get to them through kayaks. But it doesn't really matter how you get there. Our motto is to go to the people. So the idea is to suspend our reality and meet them in their reality where they feel comfortable. So for example, things like RV medicine, while it's good and it certainly has its place, we don't consider it street medicine because RVs are typically licensed. They're places that we've arranged ourselves. So we're kind of getting them out of where they feel comfortable into our space. Next slide. So the way we view street medicine and how it's evolved over the years is when I started in 2007, street medicine was really seen as transitional primary care with the aspiration of starting them with care on the streets and then transitioning them to a brick and mortar clinic. And as time went by, we realized that that aspiration was just a little bit too much. And therefore, it was our duty to provide the same quality of care on the street that you would expect in the clinic. So this is our team. We travel via this pickup truck with backpacks. We know that healthcare is much more than the office visit. So we dispense medications, draw labs. We can do other diagnostic testing like point of care ultrasound and EKGs. The whole idea is that everything is done completely on the street. Next slide. So just like many of you, we practice directly in the encampments. We actually don't even have a brick and mortar clinic. Next slide. And we also do things like very high level wound care. This is a gentleman who has a opiate use disorder and had been injecting into his hip. He was admitted to the hospital and needed a surgical debridement. They wanted to do something called a wound vac, which essentially is they pack the wound and then they put kind of a vacuum on the wound and try and bring the sides of the wound together. So it's a very long and complicated process. He wasn't interested in staying for that, so we had to do all the wound care on the street. So this involved daily dressing changes. So we have some complex wound care things like this, but we also follow patients longitudinally for their primary care needs like hypertension, diabetes. We do MAT on the street for folks with opiate use disorders, as well as probably the highest level of behavioral health that you can expect from a scope of practice for primary care. We don't have a psychiatrist. Next slide. But more important than what we do are the values and philosophy that we bring to it. So we believe that care should be patient-led. Some of you may have heard about patient-centered care. And in my deranged mind, I picture patient-centered care. What has become of it is the patient is like buried in this hole, and then we've constructed the system so high around. This is not unique to healthcare. This is true in homeless services too. So high around that you can't even find the patient anymore. They are somewhere in the middle, but you can't see them. So in street medicine, we aim to raise the patient's voice above that of the system. So we truly view it as patient-led. We talk about street medicine about being reality-based. So some of you may have heard of evidence-based medicine, and evidence is a great place to start. But life is not a double-blind, randomized controlled study. So we have to learn the evidence and then apply it to the reality of the streets. We have unconditional respect for our patients. One of my friends that does street medicine in Southampton, England, coined this term, one less FU. So how that works is you go to a camp and they chase you away, F you, F you, F you, F you, and like 20 times. And then you come back the next time, F you, F you, F you, and it's only 19 times. We consider that a measure of success. So that no matter how many times we're FU'd away, we have unconditional respect for them as people. We see medicine as an instrument of peace. So we go, just like Doctors Without Borders and the Red Cross, we go in, who goes into war-torn areas and is seen as being there to help. So do we go into areas that sometimes look similar and are seen as being there to help. That's one part of it. The other part of it is that there's evidence to show that the reason why a lot of the people we serve don't come into traditional healthcare is because of previous negative experiences. So while we would like to believe this is just universal to all systems and organizations, that's not true. This is a reputation that we've earned. So part of us going out to them is to try and bring peace and heal some of the wounds that we've created. Lastly, we view medicine as a tool of advocacy. So it is common for me, not as much anymore since COVID, but before COVID, to be under a bridge and then within an hour in a boardroom. Now it's within an hour on Zoom. And when you're under there, you see things that you can't unsee. And you get to experience these things and walk that journey with the people that you serve. And when you do that, you become a witness. And as a witness, it's your duty to go back to people that haven't seen these things and report to them what you saw. Next slide. So we all know that LA has a homeless crisis. And we throw around these numbers and they're really big numbers, but I wanted to show you this slide to put it in context. So this is the unsheltered point in time count, just unsheltered, for the city of LA, which is the dark blue, and the county of LA, which adds into the light blue. And then on the right compares it to the unsheltered point in time count for the rest of the cities in the United States. So again, this is unsheltered. And with all of these cities, we're still shamefully ahead. So the point of this is that this is not a problem that's ever been solved to this scale before. So as we're thinking about how to address it, I think one, we have to respect the problem, and then also respect all of us who are involved in trying to solve it, realizing that we don't have a model that's worked on this scale, and that we're all doing our best and to just be kind to each other. Next slide. What makes LA so difficult, and one of the things that really struck me when I got here is that when we think about homelessness in LA, and you guys know this already, we typically think of Skid Row. But the truth is that less than 10% of the unsheltered homeless in LA actually live on Skid Row. But like a vast majority of the services are located on Skid Row. So it is common for us to have patients not there who are getting 2 to 3 meals a week. Next slide. And a lot of the patients live in areas that look like the places I used to go in Pennsylvania. So when we do street medicine, we take the environment into consideration and we teach it differently based on where the patient lives. If it's on Skid Row or here, you know, in these places, we teach things like that have a lot to do with camping. You know, how to purify the water from the stream that they're in, where to go to the bathroom, and different ways of sanitizing. With COVID, the education we provide on places like Skid Row is different than what we provide out here as well. Next slide. The reason why we care about this so much for this population is that the unsheltered homeless have 3 times higher mortality than the sheltered homeless and 10 times higher mortality than the general population. But I think what surprises people are the things that they die from. So top 2 causes of death are not, you know, drug overdose and substance use disorder, but actually cancer and heart disease, things that we typically address with primary care and preventative medicine. You know, one thing to note is that in Los Angeles County, the #1 killer of people experiencing homelessness is heart disease. It's actually the #1 diagnosis that we see. About 20% of our patients have congestive heart failure. So when we're thinking of what we should be sending out to the street, we should be providing services for them for the things that are killing them. We know that there's a housing crisis as well as a homeless crisis. And providing medical care, the things that they're dying from, should not be predicated or contingent on them having housing. So we have a duty to provide it where they are now. Next slide. And from a healthcare perspective, this isn't helping anybody. So compared to people who are housed, they have much higher ED visits, much higher readmission rates to the hospital. When they come to the hospital, they stay for a really long time at a higher cost per day. So this isn't good for them. It's not good for the system. And a major reason for this is this. Having a primary care physician, unsheltered homeless, 8% versus 82% for people who are housed. Where I came from in Philadelphia, we showed that we could decrease ED visits by 80%. We haven't been able to pull that data yet here, but this is the reason why. If you can imagine that there's no more primary care doctors, no more outpatient clinics, and the only point of entry into the healthcare system is through the ED, you can imagine how ED visits would skyrocket. So we weren't doing anything special except providing an alternative entry point into the healthcare system in a way that was accessible and acceptable to them. Next slide. As I mentioned before, there's evidence to show that they have been discriminated against in the healthcare system. So this is our role in it. And a recent study showed that there was significant disparities in hospital care mortality between homeless and non-homeless adults with cardiovascular conditions. The same thing that's their #1 killer. So we are partially culpable with this. So this is how we have tried to address the situation at USC. Our vision is that all unsheltered homeless in LA have access to basic health care. We know that we can't do this alone. So the program that we designed is essentially designed to build capacity. We started with a hospital-based consult service at LAC-USC using inpatient admission as a proxy for medical necessity, thinking if they were admitted for something, they would need follow-up for something on the street. And in fact, that's true. The patients we meet in the hospital are much sicker than the patients we meet on the street. We have a street-based care. We have a workforce development and training curriculum. So right now we're just finishing our first cohort of 6 federally qualified health centers who have undergone a year-long training in street medicine. And then of course, research to continually prove and improve our model. Next slide. So these are just some of the basic data points that we track. So we showed that we could decrease the length of stay in the hospital by 3 days. For those of you who are not familiar with these type of metrics, they're standard metrics. This one in particular is usually measured within hours. So decreasing length of stay by hours. So a 3-day decrease in length of stay is significant. Next slide. One of the things that we're most proud of is establishment in primary care. So what happens in the hospital is patients seen in the hospital found to have unsheltered homeless, or to be unsheltered. And before street medicine, they would be given a referral to an outpatient primary care provider. And the same happens a lot on the streets with the MDT teams, or even ones that have street medicine but are not providing care on the street, is they rely on these referrals. There's one particular healthcare for the homeless clinic that they referred to, and the no-show rate for the clinic was 90%, 10% show rate. The show rate for any clinic from these referrals is 27%. And with street medicine, we've been able to actually connect them and provide ongoing primary care to 70% of the patients. So this would be the first step in really providing any care is to find them. Next slide. Another thing that we look at is hospital admissions and hospital readmissions. So on the left, this is kind of life without street medicine. So there's been one study that showed that 50% of the time when somebody leaves the hospital, they'll be back. At LAC-USC, 37% actually do come back. Lehigh Valley Health Network, where I was before, our readmission rate was 11%, and LAC-USC, the readmission rate is 10%. So I think the importance of this is one, it shows you the value of providing primary care on the street. Of course, there's a financial value to the hospital, but it also shows that this model is reproducible. Next slide. Another thing that we're really proud of is when we go to the hospital, these are all patients that are supposed to be discharged to the street. And about 30% of the time we can avoid that discharge. In fact, of all the patients we touched last year, 42% found housing. This was prior to Project Roomkey, which made it a lot easier to find housing. And it's not that we're so great at housing. In fact, we don't do housing, but we have learned to collaborate and to work really well with our community partners. Ideally, we all get to do what we do best. So we don't do housing best, but we partner with the people who do so that we can concentrate on the healthcare. We found a lot of people to be extremely sick on the street. Some have significant disabilities and need nursing homes or boarding cares or other higher levels of care. And in order to get into that, they need to see a physician and to get physician paperwork signed. So just like having a family member who is watching a grandparent deteriorate in the home and can tell the doctor what's happening in the home, we can see that what's happening on the street. So a lot of the patients that we see are very sick and we get them into the higher levels of care that they need. Next slide. But the only reason why any of this works is really our approach with radical humility. And one of the things that we talk about a lot is solidarity. This is something that has been in the news a lot with statements of solidarity, gestures of solidarity. And I just wanted to share with you how we see solidarity. So in order to have authentic solidarity, when you're on the street, like I said before, we see things, and the deeper you get, the more suffering you see. And the initial reaction is to actually hate the people that are causing the one that you love to suffer. But authentic solidarity doesn't do that. It shares in their suffering with love. Solidarity is also inclusive. So you're not in solidarity with one group in opposition to another group. You can be in opposition to an injustice, but not opposition to a person. So solidarity should be inclusive. This picture was actually drawn by my 12-year-old daughter, Abigail, and I think she understood it. She understands this concept really well. So on the top is charity, and I think this is what we see most common. So this is a street medicine provider who is reaching down to drag somebody experiencing homelessness out of a hole. And sometimes they might be successful. They might pull a lot of people out of that hole. But if they fail, what's he going to do? He's going to stand up and walk away, leaving them to suffer in isolation. But solidarity gets in the hole with them, gets underneath with their back dirty, boots dirty, and pushes them out, shares in that suffering with them, in the hole with them. In fact, this person is going to get out first before we would, but we have more resources than they do, and we'll find a way out. Next slide. But what I love most about what we do is really the joy that we experience. So we really have a deep love for our patients. Most of our days are filled with this kind of laughter on the street. You know, even though we talk about suffering with love, it doesn't feel like suffering when you're doing it together.
And do we go to Renee now, or is that how? Do you have a presentation as well, or I just want to make sure I understand how we're doing this?
I do, but I wanted to see if anyone had specific questions for Brett before moving on, because that was fantastic.
All right. So if so here's how we do it on Zoom. If you haven't been with us before, if you have a question, just open up your participants panel and hit raise hand. And then when I see your hand raised, I can just call on you in the order that you've raised it. So let's go to George Chen.
Thanks. Thank you, Brett. What is the funding source for the street medicine?
So like many nonprofits, it's a patchwork of funding. We get some funding from the university. We have two teams operating right now. One team is contract based. We get some grants and philanthropy. Street medicine is not easy to bill for. It's actually really, really difficult to bill for, if you can bill for it at all. So we are working at the state level to try and get some bureaucratic stuff that I think we can get changed over time, but right now it's not set up that way. So so really most of the longer term sustainability is through contracts, unfortunately. At some point, we'd like to get to the point that we can get paid for the services we provide.
Okay, thank you.
Okay, good. Gabby.
First and foremost, thank you, Brett. What you guys are doing out there, I think we can all agree is extremely just, beyond God's work. It's work that we wish we could have accessible to us when we visit many of our encampments. And I think that leads to my question in terms of how are encampments selected, and how do you partner, or should I say collaborate, with organizations that are also targeting these encampments through other services and other means?
So as I mentioned, we have two teams. The first team starts at LAC-USC in the hospital and picks up patients who are admitted, and then follows them anywhere in the county where they go. So that's how the patients are selected. We understand that they live in communities. So once we find them where they are, we also have the ability to take care of the rest of the encampment. If there is already an outreach team working there, we of course try to identify who that is, where they are in the process of whatever it is they're working on with the people in the encampment, and try and find a way to be helpful. Our second team is paired up with a MDT team in SPA 3. The way that we work with our MDT team is a little bit different from the way that the others do. And I'm happy to, get into that if you guys are interested in hearing why or how we do it differently. But that's how the second one is. So essentially anybody within that SPA would be available for us to see.
And then just really quickly, if I could just follow up with you after this, I'd like to discuss just the funding a little bit deeper. I know the local hospitals in our area have been interested in this, and just seeing how you guys fund it would probably be a good way to partner up and reach out to the legislator together. So thank you.
Excellent, thank you.
Okay, thanks, Gabby. John?
Brett, thank you so much. I saw this program on PBS feature not too long ago, and it was so inspirational to see you guys working. I just wanted to ask specifically, is there a best practices kind of toolkit on the program if a local agency wanted to approach a hospital in their area or a large medical services provider to kind of emulate what you're doing? Is there that kind of consultation available at this point?
You mean for us to provide a consultation for another agency to start a consult service?
Yeah, if we wanted to reinvent your program locally in a city or a region, is there an available kind of how-to guide, if you will, both on an administrative and more importantly on the medical side of things, which we're not experts in, as to how we could approach the feasibility of this with a local medical provider?
We actually just presented a few weeks ago at the International Symposium about how to, it was like creating a toolkit to set up your own consult service is what the presentation was. But we haven't published anything on it. We actually have an article about how to do it that's under review right now. But if you want to reach out to me afterwards, I'm happy to talk to you about it.
Okay, George.
Thank you. Brett, I have one more question, and I just want clarity is street medicine. So you're actually just trying to get out there. The focus is providing, I know you have charity and solidarity is the medication. The example you have, I think the person who had a hip problem, I think due to, I think you say heroin or something like that. I'm trying to connect, focus on medicine for illness, but is there a connected strategy to get them out of substance abuse? Because they'll continue this, it'll be a cyclical, a cycle. How is there a strategy to get them out of that addiction? Otherwise, it's kind of like, give a person a fish, you feed them for a day. Teach them how to fish, you feed them for a lifetime. I'm trying to see, or is this just purely, they got illness with a doctor, we want to just take care of that.
So we have a drug and alcohol counselor on the team. We provide MAT on the street. So we can do an induction on the street and refills on the street. But ultimately, you're right, as long as they're on the street, it's going to be hard for them to stop using, which is why we work so hard to get them off the street.
Okay, next question is from Y. Slater.
Hi, fight on, by the way. I'm a USC alumni. I'm from the Gardena Police Department. I'm a med officer. And I wanted to know whether or not, usually when it comes to encampments and homelessness, we're often the first point of contact. So are we able to do a referral, or do we have to be working with an outreach person in order to obtain those services for someone in need?
So we don't, did you say Gardenia?
Yes, Gardena Police Department.
Okay, so if it's an area that we cover, so right now it's SPA 3 would be the geographic area. So if it's in an area, then we would receive referrals from anybody working in the area, including the police department, and we do receive referrals. I think Pasadena Police Department has been the one that sent us the most. But not if we don't have a team in the area.
Okay, so you would, in order for me to give you a referral, then it would have to be a team in the area. That's how it would work.
Yeah, we would have to work on starting a team in the area. And like I said, our vision is that everybody sleeping on the streets of LA has access to basic health care. So we know that we'll have to expand what we do in order to do that. But we're also open to training and equipping others to do that as well. I know there's been some other police departments in the area that were interested in this type of service because they get a lot of calls for people experiencing homelessness that don't necessarily need, police intervention or even EMS. So, so anyway, that's something that we're interested in exploring as well.
Okay, thank you.
Okay. Any other questions for Brett? All right, if there aren't any more, Brett, will you share your slide presentation, or maybe Grace, you already have it? I got a private message from somebody who was wondering if they can get a copy of it.
Yeah, we do have it, and it is available on the COG Homeless Services Task Force webpage.
Okay,
and it's already up there.
Great. All right, wonderful. So then why don't we now transition to Renee?
Awesome. All right. So I have a presentation as well. I don't know if there will be a screen shared from your end. That would be fantastic.
There it is.
Thank you so much, Brett. It's great to meet you virtually. I've heard a lot of wonderful things about your program, and you gave a wonderful summary of all of the kind of key things that provide the foundation of street medicine. Yeah, I've heard great things from Lauren Freiling, who's also at Harbor through the emergency medicine program. So hi to everyone virtually. I'm a third-year family medicine resident at Harbor-UCLA, which is in SPA 8, down in the Carson-Torrance border, however you'd like to call it. So we can just kind of get into a brief summary of, again, the background of the importance of street medicine in our unhoused individuals and what we're trying to do to try to serve the individuals out on the streets and kind of meet them where they're at. We actually had a meeting like 2 hours ago, and Lori Ramey's also on the call, so hello again. And there's a lot of stuff that we'd like to accomplish. There's a couple of things we did prior to COVID, more in the sense of setting up an actual clinic, but we're trying to reinvent that now. So not as established at this moment, but we're working on it. So we can move on to the next slide. So I just included just the SPA 8 greater homeless count information that you guys can kind of look through. It's just a screenshot of the top half, but it's basically just sharing that, homelessness is so pervasive in the county. It's not going anywhere. It's something we have to continue to work towards finding resources for our unhoused individuals. The numbers are pretty consistent, specifically looking at families as well versus individuals. I know that Project Room Key has been wonderful with opening up new sites. There's been some bridge housing, some other shelters that have been available. And now as we enter winter time, there will be more shelters opening up. But again, trying to get to the root of the issue and getting more permanent housing available for all individuals is ultimately the goal. Next slide, please. So with this, you guys can go through the numbers, and these are kind of rough estimates, but definitely there's the increase in homelessness from previous years, with a good number of individuals who were housed. But kind of the bigger thing here I wanted to touch on was that unsheltered individuals have a 10-fold larger all-cause mortality than their housed counterparts. And a lot of that is, what Brett had mentioned already, the increased barriers to accessing care, not just medical care, but again, whole person care, access to social services, to the resources that could provide housing in the future. So there are a lot of barriers there. I think street medicine tries to initiate that with medicine itself, but ultimately we need the collaborators, we need our community partners to break down those barriers and starting by meeting individuals where they're at. Next slide. So this is from a study back in '97 that just showed I want to highlight just the difference in ages of mortality between individuals on the street and housed individuals. So I think the big thing was that the mean age of passing was 47 with a median of 44, which is very, very young. And, there's a lot of reasons why individuals unfortunately passed earlier. Brett had mentioned cancer and heart disease. And there's a lot of kind of chronic comorbidities that, when not treated, unfortunately lead to earlier and more prevalent mortality rates. So a lot of things I mentioned in this slide, like renal and liver disease, arrhythmias, cardiac problems, substance abuse, in relation to mental health disorders, cancer as well, kind of cold related problems like frostbite, hypothermia, and immersion, kind of for maybe more individuals on the East Coast, maybe less in Southern California. But it's just the fact that there is, basically like a 35 to 40-year difference between our individuals who are on the streets and those who are housed is, very kind of mind-blowing, when you first kind of look at it. When I saw it, I was just like, what can we do at least to try to, change this even a little bit from our standpoint. Next slide. So there are some challenges. Again, I don't want to kind of repeat too many things, but there's a lot of complexities that go into providing care. Again, establishing trust is a huge thing. Coming in for the first time, like Brett said, it can take a lot of times to really establish that care. And a lot of times you get, shown the door, or you're unable to do anything, but just trying to be persistent, come back and say, I'm here if you need us. We have services available, like you don't have to talk to us now, but come back. Is something that we try to do, and as we will try to do in the future with kind of a more robust team, again, is to try to establish that trust as best as we can. And unfortunately, a lot of times we see patients who have more advanced stages of disease, like very progressive and very decompensated heart failure, very decompensated liver failure, where a lot of times we're meeting them at those end stages, and it's heartbreaking at times. And we try to connect those resources, we try to connect that medical care, but like Brett said, ultimately, like housing is the best thing to really try to make sure that we can ensure that more of those resources are able to be provided more consistently. Next slide. And this has again been shared, but the idea of street medicine, ultimately we want to increase access to care. It's innovative, it's cost effective, and it can improve our health outcomes. We don't have numbers from our end that prove this, or we don't have studies yet from our end. We're very much looking forward to doing those once we have a more consistent program. But it has definitely been shown with other wonderful programs across the country that it does improve health outcomes. And from a primary care standpoint, we love that. We want more of that, and trying to find ways to become more innovative is key, while providing, evidence-based care out on the streets with the supplies that we have. And another important thing too is focusing on collaboration with our multidisciplinary teams. And a lot of them are already going out and doing fantastic work. So how can we as medical providers come in and, collaborate with them and work with them to provide those medical services, so we're able to bridge the gap there. Next slide. So this continuous care model was shared in a previous presentation I had been a part of with the National Health Council for homeless care and homeless medicine. But basically the idea that the street medicine team is the foundation for, being able to provide a lot of these services out, whether it's back to the streets, to the shelters, clinics, et cetera, as you see there. But again, really being able to be a positive and consistent presence in our unsheltered friends' lives. Next slide. And this patient kind of centered care model is, again, I called it patient centered because that's usually the first thing we think of, is that, again, as providers, we really want to focus on the whole person, how we can provide this care outside of just like their health, but through everything. And as you can see kind of listed, all of this stuff is so important to the model itself. This is what we hope to get with our future partnerships and establishing a model that's not only all of these things, but again is, as I'm forgetting the word, is longitudinal and continuous and is able to be continued beyond the kind of initial providers who started it. Next slide. So who we are, this is just basically what I hope that our program will become, and it sounds like we are working towards that, is basically multidisciplinary, multiple departments. I mean, our county is huge, the Department of Health Services is huge, and there's a lot of moving parts. So the Department of Family Medicine and Emergency Medicine are the two within the hospital that are really driving this and would provide residents and attendings and providers to support the medical side of things. We also are planning to collaborate with the Department of Mental Health, whether it's bringing psychiatrists or working with the Department of Mental Health counselors, again, to bridge the gap there. If we're able to work with LASA, city nursing, that would be great. And ultimately, this is also a place where maybe funding could come in as well, which we're looking at is working with whole person care, which is also a wonderful branch of Harbor-UCLA's department. And they do a lot of great work, and there's a big opportunity there, and maybe we could potentially work with them as well, still pending. Next slide. And just a background on our DHS services. So we're the second largest municipal health system in the country. We've got 4 acute care hospitals, including LAC-USC, which is actually the largest. Many ambulatory sites, many partner clinics, and we see quite a few patients each year. This doesn't include people we will see on the street, but that is something we're trying to include in the future for metrics. Next slide. And with Harbor specifically, you can see the kind of details there. What stands out a lot is the 55,000 primary care impaneled patients and 300,000 clinic visits and the large number of residents and fellows in training. And just ultimately the catch area that we have. So Spot 8 itself is kind of at the lower end, but the medical center itself reaches out as the basically only county hospital between, I guess, Carson and the border. I don't think there's any in San Diego or Orange County. So we will see all patients regardless of ability to pay, and we're able to impanel them to our services with restricted Medi-Cal so that they're able to get that care, particularly when they are diagnosed with various conditions that need more consistent treatment. All right, so next slide. So again, as Brett had mentioned, there are a few kind of pillars to our goals for care for our, unhoused individuals. So big thing is health equity and advocacy. A lot of our residents, our program, emergency medicine, we all chose to be in a county hospital. We want to serve underserved individuals. We want to remove those barriers to health and care, and we want to provide equity where we can. And by being the best providers we can be stronger kind of players in the community to advocate for the sometimes non-medical things that, our patients will need. So that's a very big thing that again goes with the mission-driven aspect that's a little bit lower at the bottom. And harm reduction is another important aspect. So just this set of practical strategies that reduce negative consequences of drug use potentially. There could be other things that could be reduced in sense of harm, but we usually put that together with drug use sometimes. And just providing a spectrum of strategies for safer use, managed use, abstinence. We are trying to be as realistic as possible. We go out and serve clients and trying to help affect behavioral change. We don't think people are going to stop using completely, but let's try to meet you guys halfway and try to develop these new behaviors where ultimately we're able to kind of reach more trust between ourselves and our patients and again, reduce harm. And as you can see on the other things, they're pretty straightforward, access to our facilities and to specialty services on top of our primary care. Next slide, please. So this was just a mission that we had put together mostly for like funding based. And as Lauren and I were kind of looking through some things, but you guys can kind of read through it. But ultimately, the goal is to be multidisciplinary, working with our social services and then providing as much care as we can to our unsheltered individuals in and around our direct area, if not within the entire SPA in SPA 8. So ultimately, by going directly to our patients, we're able to gain more insight into what those barriers actually are, and then trying to provide tangible examples and changes in policy that could remove those barriers in the future. I know it's a very wishful, optimistic goal, but we'll work on it piece by piece. Next slide. So the structure, I just kind of created this idea, but we can go into each piece briefly. But patient care in the medical home, whether it's on the street providing the medical home or if they're able to come to clinic, every individual is different. Some individuals don't want to come to clinic, and if we can provide all the services outside, that would be fantastic. But ultimately, sometimes we're not able to get those services like labs and medications directly dispensed out on the street. Then it would be great, for example, to come to our clinic that, for example, is a mile away from one of the larger encampments on site, or being able to establish care there. And then if we need to, we're able to get the medications, get those things, and bring it to the individuals on the street. We can go into the next slide. The patient care is pretty straightforward, but again, bigger things is enrollment and social services, building trust. Other things we were thinking of today actually on the call was like possibly creating a triage line where if other individuals who are going out on the street, like for example, law enforcement, EMT, other nursing, were going out there and there wasn't a doctor or another provider who was out there, they could call this line and they could be patched through to someone in the clinic or in the hospital, one of the providers, and kind of go from there. This would include wound care, chronic condition treatments, medication-assisted therapies, and even long-acting antipsychotics and management of other mental health comorbidities, because everything ties together. And then in regards to collaboration, on the next slide, we would love to partner with our social services and outreach groups. We actually just spoke with Lori Ramey with our E6 street teams and other multidisciplinary teams around Harbor. And it would be so wonderful, it sounds like we're gonna do this soon, is be able to be a part of these multidisciplinary teams that are already going out and doing fantastic work. And now we'll be able to add the medical component into that. Just so again, it really rounds out the total care that's provided to our patients. And in regards to safety, this is something that we will really try to hone in on. Next slide, please. A big thing here is just establishing protocols for training everyone that's involved. I think from our end, as sort of a liability coverage of our providers and through the DHS system, we just want to make sure that we have someone who's also there with a community outreach worker who's familiar with everything, and just making sure safety is still something that we're focusing on, definitely of our clients on the street and for ourselves as well as the providers. And then in regards to education, this can be a kind of two-part thing. So definitely a formal orientation and education provided by experts in street medicine, people who have been doing it for years, decades, who could help with this. And then we would love to create a sort of curriculum that could be available for trainees in all areas of the healthcare field, not just MDs, DOs, and even potentially creating formal protocols for nursing and EMTs and those, again, who are out on the streets, where they're able to follow, evidence-based guidelines, like for example, like with cardiac arrest or with a very severe wound or a leg ulcer that's not healing, like what can be done in the meantime before needing to reach out to, again, other providers. And there are two kind of setups for clinics or that we were previously doing. We can go to the next slide. One was a structured outdoor clinic where we had an attending, about 3 to 4 residents, some other students, whether in college or high school. We'd had an outreach member as well and a pharmacist. So this was kind of like a basic setup that we had. And going to the next slide, our family medicine clinic was running it out of Journey South Bay. Our goal was trying to do it once a week, but then as COVID became more pervasive, it became once a month, and then we're actually on hold right now. But we would basically bring this clinic and set it up during mealtime services. So individuals who wanted to be seen, they weren't in panel, but like we set them up, do their vitals, see them for their specific problems, and we would be able to provide medication, wound care, sometimes treatment for various dermatologic issues, because that's always a big thing. And then providing some teaching both to medical students, residents, undergrads, and sometimes some high schoolers would be there as well through UCLA and their extension program. But this is on hold, so we will see. The next thing is the more like on the go kind of street team, which seems like it's going to be more feasible, fingers crossed, where we are joining with current multidisciplinary teams to go out to meet individuals where they're at on the streets in various locations during the day and providing medical care where we can. And that could be on the streets and with individuals who are newly housed, and then providing a warm handoff to the other outreach services that are more affiliated with the housing. And our location, this is a nice little sliver of Spot 8, but I specifically focused on one of the larger encampments in the South Bay. So this was on Lomita and McCoy, kind of near the 110 freeway, kind of closer to the border of Wilmington, but more so in Harbor City. This is very close to our family medicine clinic, pretty close to the hospital, but this was an area that we were focusing on a little bit more last year, kind of getting more needs assessments, trying to figure out what we can do to help serve the community. I know that after speaking with Lori, there's a fewer individuals there now, but there's a ton of need all over the spot itself. And we are very much looking forward to being able to go out there with their team to provide medical care. And then just again, to reiterate why street medicine matters, it benefits everybody involved and those who aren't even asking for it. You know, it saves money, it improves our health outcomes, and what we want to do is ultimately increase access to care, remove those barriers, meet people where they're at, and connect everybody with services collaboratively. So yeah, I mean, it's a very promising solution. We were put on hold a little bit, but here are my references. There's quite a few, and hopefully we could potentially decrease a lot of the morbidity and mortality in this very vulnerable community, and we shall try. So here are a few people to say thanks to who are also working very hard and tirelessly to make this happen.
Great.
Sorry, I went a little bit over.
That's okay. That's okay. Are there any? Zulma, go ahead.
Let me unmute myself.
You're unmuted.
Okay. Hi, Renee. That program is amazing. I had a quick question for you. What relationship do you have with other medical institutions in Spot 8?
Yeah, so great question. Actually, from my knowledge, outside of our affiliation with UCLA Health System, in the sense that we work directly with their medical students and sometimes with nursing, I'm not sure if we have a direct affiliation. I know the hospital does with some nursing programs, but we would be very interested in connecting with any kind of schools that are in the area. But from what I know through Harbor and through DHS, we don't have that direct connection with anyone in the spa. Doesn't mean we can't.
Thank you.
Matthew?
I'm curious about what is the goal for like turnaround rate? Like, so if I'm outreaching with unhoused folks and I have somebody who needs medical attention and I contact you, what is like the expected time to get people actually out to people? I guess that's my question.
Yeah, great question. So again, we spoke about this earlier today. The goal would be to, again, go out weekly with the street teams when they're out there to provide that care. I think we might have to realistically start on a monthly basis, because as residents, we would need attending physicians who are kind of past their residency training to be there with us. So it's just it's a little limited right now because of the amount of individuals we would need kind of consistently going out. But our goal would be to have someone at least weekly going out with the team to provide care. And if there's something that needs to be handled more acutely, if we're able to get a triage line, that would be great to utilize as well. But kind of tentatively, our goal is to be about a week, if not a month to start.
Great. Thank you. Are there any other questions for Renee? Gabby?
Thank you. If you could just put your email address, please, in the chat, if you don't mind.
Yeah,
Thank
absolutely.
you.
I will do that. And again, this is all stuff that we're hoping to achieve soon, but what we tried to do previously, and we hope to get kind of up and running with the MDT and E6 teams soon. Yeah.
Okay. Well, thank you so much. Thank you, Renee. Thank you, Brett. Really appreciate that. That was super informative. All right, we're going to move on to our next topic here, which is the Caltrans protocols for homelessness during COVID-19. And so, China, I think that's you.
Yeah, that's me. Thank you so much for having us. My name is China Gerstner. I'm the liaison for homelessness related matters. I represent Caltrans, but I also, when I'm not working remotely, I work within the Unified Homeless Response Center led by Mayor Eric Garcetti. And we work as a collaborative team on areas where we have bordering jurisdictions with the city and other partners within the UHRC, like Recreation and Parks. And then we do joint cleanups at times with LA Sanitation. So today, I'm sorry, I can't see all of my slides, but I do know what the content is. So today we're going to talk about Caltrans operations and how we can best partner with various cities and counties where we have encampments that are on Caltrans property. So the guidance for our landscape maintenance staff at this time during COVID comes from our headquarters in Sacramento. So right now we're in our 6th version of our maintenance policy directive, and it's extended to December 31st. And what it says is that our staff will refrain from cleaning an unsheltered encampment unless there is an immediate safety concern. And this guidance comes to us through headquarters, and it's the guidance is provided by the Centers for Disease Control, California Department of Public Health, and CalHR and others. Next slide. And so we're going to talk about the treatment of unsheltered individuals experiencing homelessness that are on our right-of-way. What we do is when there's unsheltered individual housing made available, we want to ensure that we're following the guidelines to plan coordination for their treatment. So if we have individuals in our right-of-way, we cannot relocate them, as it would disperse them throughout the community, possibly spreading COVID. So just like we shelter in place, the expectation is that the unsheltered are sheltering in place on our right-of-way, on our property, and with the social distances. And unless adequate COVID appropriate accommodations are made available, that's where they will stay. Next slide. When we have a direct request for relocation, this has to be elevated through coordination to our headquarters through our district maintenance chain of command. Emergencies are prioritized, and then we look at the location to determine if it's unsafe for the unsheltered person, the traveling public, and then our supervisor and superintendent decides based on their assessment if this should be elevated to headquarters for a request for relocation. And again, the request can be initiated by another government agency, but it has to be assessed in terms of the priorities attaining to the level of emergency or urgency. And then that coordination for requests should be streamlined. It should come through a point of contact that's designated by a city or a county, And that coordination should come through me as the liaison for homelessness. Next slide, please. And as part of Caltrans partnership within the UHRC, we extend this across both our districts, both our counties. We encompass both Los Angeles County and Ventura County. So we partner with approximately 80 plus cities. And so when we find out about an encampment, we want to identify all government agencies responsible for the health and safety of the unsheltered individuals in that community. Because they are part of that community since they are living within that city or county. So what we want to determine is all the agencies that have jurisdictional responsibility where that unsheltered person is encamped. And we want to ensure that all the agencies are notified about specific issues within their jurisdiction. For example, we may partner with Metro and Union Pacific Railroad at a site that has a lot of known criminal activity. So we have, various law enforcement entities that are communicating with us in real time as to what's going on. So we want people to be safe at all times. So we give all the information that we can to make sure that everyone is prepared to meet. And sometimes we'll meet on site. We'll meet with all government agencies to discuss the location. We'll develop an independent action plan for each jurisdiction and then create like a joint plan so that we can all rendezvous to address the location. Next slide, please. And then what action we take, if possible, we'll coordinate the relocation, and that comes through COCs communicating with their outreach partners and various partners of availability for unsheltered individuals to safer COVID-19 appropriate accommodations. And we'd like to create strategies to decrease this area from being breached again in the future. We've had areas like bridge sales and storm drains, places that are just so unsafe for folks and even unsafe for our first responders to come in there. The threat to loss of life for the unsheltered, to our first responders. We want to really develop some action plans to relocate when we can. And if relocation isn't possible, and sometimes it's not because of a capacity issue, and we understand, we want to work with folks to make sure that we keep everyone safe. Safety is Caltrans' #1 priority. And so what we'll do is if there's a city jurisdiction, we'll go in and we'll do a joint cleanup and use our hazmat, litter and debris removal. And we'll talk more about that later. And then we'll perform, not us, but we'll use our partners and they'll perform outreach to educate the unsheltered individuals in that area. Sometimes it's a construction zone and we just really, we want them to be safe. And as far as enforcing, we develop a plan with the respective law enforcement agency to relocate reluctant unsheltered individuals. And again, it's just to ensure their safety and secure our infrastructure so there's no threat to the traveling public. Next slide, please. So some of the things that we have been doing just so that we get cities and counties to understand how we can better partner for the unsheltered, #1. But there's a lot of litter and debris out there that citizens are concerned with, and so are we. But we also know that if you have no place to live and you're living on the streets and there's no receptacles around and there's no restrooms, it creates a lot of litter and debris. So we like to designate a point of contact within the city or the county that can reach out to me as the liaison, and then I could further coordinate our efforts. And then we do have a volunteer program. It's called Adopt a Highway program. It's fantastic. And we could share Adopt a Highway program with any city, county that would like to hear about this program. And you might have seen the signs along the freeway and highway where it shows it could be a neighborhood, it could be a business, it could be anyone that wants to enter a volunteer arrangement to adopt portions of the highway, we'll let you know what parts are adoptable. And then there's a request. You can request a 3-day permit to implement a designated location that you like to clean up in your city, your county. We also have something more involved, and that's a landscape maintenance agreement that would require speaking to someone on our team that's skilled in understanding the way a city or county would enter into a landscape maintenance agreement. Next slide, please. And these are some of the impacts that I think it's important we share during this time, because it's really changed our operations. So the funds that we have, we allocate to hazmat contractors because safety's our number one priority. So we are not using our staff. As we said, we're under Maintenance Policy Directive 20-02, Revision 6. And so this cost is very high when we use hazmat contractors, and we're using them for all of our operations at this time. Litter and debris, anything associated with an encampment where there's biohazards. And also, one of the things that we've experienced is a decline of over 450 community service workers that we would typically use to go out and assist with our maintenance landscape crews. And the other portion of that is we have this really amazing program called Road to Second Chances through Chrysalis, one of our partners. And we've had a decline of 140 people that are on active supervision that would typically help with landscape maintenance crews. So we are down 50, actually close to 600 people. So that leaves us with 166 landscape maintenance workers to maintain 6,300 acres across LA and Ventura County. So these are our impacts. And then we have something called the Customer Service Request System. And it's a portal where citizens, elected officials, everyone uses this portal to show what the needs are in their respective communities. And right now we're up to 1,500 CSRs, and some of them are redundant because of the people who feel that they're being ignored. And it's not that we're being ignored. This is our reality. Next slide. So I just wanted to talk about our encampment prioritization. When I say that, we prioritize in terms of emergency safety, we have situations where occupants are connected to high voltage wires that impact our systems and our operations. So these are the level one, like the top tier things that we're concerned with, where people are in travel lanes where they can actually be a pedestrian fatality. People are in confined bridge cells. We've had situation, and we do have situations where they breach the hangar, they go in, and it's 4 feet of space, and they're creating environments where they're living inside our bridge cells. And there are locations where there's active fires, and we have to get the people out. And then we also have the need to perform emergency inspections of our infrastructure just so that we can keep them operating smoothly. So we have to make sure that we can access our bridges and different infrastructure. Next slide, please. This location is considered urgent. When we have encampments with combustible materials, unauthorized vehicles that are parked under our structures, we have to investigate and ensure the safety of the folks and also the infrastructure, because it can impact the traveling public. So encampments and gore points, or areas where there's only access to camps by crossing live traffic, we really are concerned about and want to, get those people educated on them being an unsafe area and the need to move. Also, we encounter things like this, digging in slopes or structures. As you can see, they'll dig into the embankment or the slopes, which compromises the integrity of some of our infrastructure. And then things that conceal and block access to structures are of grave concern to us as well. Next slide. And locations where we may have time for planning, we just want to mitigate before moving unsheltered individuals. Where things are going into the waterways, we want to mitigate before moving. So we'll work with CAL FIRE and CHP to monitor severity of the safety threat. And so we'll consider mitigation first and then focus on relocation, again, with our city and county partners, just so that we can plan for when space does come available if there is some bottlenecking with housing, because we do know that those are some of the concerns for our city and county partners. Next slide, please. And in locations where there's a lot of litter and debris, we know that there's illegal dumping going on around some of our encampments. And we try to mitigate the location with trash cleanups, even with our partners with the city. And our city partners have identified this through a process where they are finding people and they're finding out who people are that are doing this illegal dumping. And but what we want to focus on is the relocation, again, with our partners, and work with the COCs to find ways to prevent moving people. Just moving them to move them is not an effective way. And that's why we're really reaching out to our partners to more align ourselves to bring them indoors when we can, and educate and make a plan when we can't relocate right away. And we just want to engage people to help people collectively. Next slide, please. In abandoned encampments, we just have to ensure that no one's coming back. This area has been abandoned, and we'll have our staff go out at least 2 times to make sure that there's nobody there. And those are consecutive times where, we want to make sure that no one's coming back looking for their things. And if it is an abandoned encampment, we will go ahead and do a litter and debris removal for that area. Next slide, please. Relocating unsheltered individuals. Relocation, we said it only happens when local partners are able to identify safer spaces for all of the unsheltered individuals. We have to answer these questions to headquarters. We say, what is the safety concern? How was it identified? If this is on a construction site, what are the impacts to the construction project? What are the timelines? Where are they in terms of where the construction phases are? So maybe, we can have them move to a different area if there's no beds available, but we do want to work with bringing them indoors, not just shooing them around during a time of a pandemic. And we do always ask for photos so that we can really get a visual on, what we're dealing with in terms of the density and the needs of the folks. And LASA is a great partner of ours, the city and county LASA. So we do a lot of coordination with LASA. Next slide, please. And then cleanup in lieu of relocation. So our supervisors go out to their locations and they're assessing things on a regular basis. And so we have to go through our maintenance chain of command to request a hazmat contractor, and headquarters is notified of all of our cleanups, as well as a relocation of folks. So the supervisor always assesses the location as he's performing his regular route inspection, or sometimes a customer service request can trigger that there's multiple requests for the same area. And then we realize that constituents are really concerned, and we really should, pay attention to this. And then we talk to the respective city, and we start to try and do some coordination around that with outreach. As a liaison, I receive direct requests through UHRC, sometimes through my city partners, because they're aware of a location on Caltrans property that borders ours, and that's where our partnerships began. Coordination should be established with the city and county point of contact with me as the liaison, so that coordination could be most effective. Next slide. And then partnering with us to improve the city and county. When we implement these partnerships within your jurisdiction, the COC and Caltrans, we can better streamline our efforts. We synchronize and operationalize with the city and county to determine a jurisdictional plan, and we develop and create action plans, and we can all come together as a team. And I always get from other partners, even Army Corps of Engineers, Department of Public Works, Department of Water and Power, Southern California Edison. What can I do as a partner to help at this site? What is it that each jurisdiction needs? We go out there, we visually see it, we put our boots on the ground, we put our hard hats on and our goggles, and we look at how are we going to do this? Like the doctors that spoke, thank you so much. We want to triage this. we want to get as many people out there to look at this, to see what we all need. And my partners always say, is there something we can offer to Caltrans? We just partner best when we do this. And so when we do this and we're successful, like we have been on some major locations like in Pacoima, Paxton Bradley, 118 Freeway, we use those previous successes in city county models to make replicable models across our district. And we are seeing those successes, and we want to build on those, and we want to continue to build and partner on those successes. Next slide, please. And so I just wanted to end with just sharing again some of the things that we could do to improve our partnership, and that is, really designating a point of contact so that we can streamline our efforts, volunteering, where people can. Sometimes people don't know what to do, and citizens may want to do something. And we've had the youngest adopt a highway person. He was 16 years old, and he had his whole family go out there. Our oldest adopter was in his 80s. He told our maintenance crews that he could make his location look a lot prettier. So he became a volunteer at 80 something. And then again, the 3-day permit. It's just a 3-day thing. It's very easy to enter into, whereas the landscape maintenance agreement is a little more detailed. And next slide. I just want to thank you for having us here to share what we are doing at Caltrans during this time of COVID-19. And I thank you for the rich presentations that I got to see. And I hope that this is beneficial for your cities, and look forward to partnering with you. Thank you very much.
Thank you, China. And if you could put your contact information in the chat for anybody who may want to contact you or Deborah. Are there any quick questions for China? All right, I don't see any, so thank you guys oh wait, hold on, one from Matthew. Go ahead, Matthew.
Well, if no one else is going to ask any questions, I have a couple. I'm wondering, how do we is there any sort of transparency that citizens or concerned citizens like myself have in seeing the process for deciding which encampments get swept? I know I've been trying to wrap my brain around how encampments on metro property get swept, and I've been really struggling just accessing that kind of information.
In terms of how it gets swept, well, Caltrans operates on a safety comes first. Things happen on our travelways. oftentimes, you see something in the news, oh my goodness, this happened on the freeway and a car goes over the embankment, and, so there are issues where, our supervisors have to focus on safety being the number one issue. And then they have their regular routes. And then in terms of the priorities, kind of laid it out, like, what's the biggest threat to safety for folks, for unsheltered, when we're talking about encampments, because I'm the liaison for homelessness. I can only speak to that. But in terms of issues related to homelessness, everybody has a fire right now because people are cooking, and so we'll get these hyper vigilant responses from the public that, oh my God, there's a fire. Well, we're aware that people are cooking and sometimes fires do happen. But when we're talking about fires where there's combustible materials and there's a threat to infrastructure, that's very serious. If we're talking about gasoline tanks that are underneath our freeways in a storm drain because people are cooking down there, that's an emergency. So our supervisors and our superintendents are the subject matter experts. I even me as a liaison, I defer to my maintenance crews. But however, when people feel like they're in a situation and they feel like, unsheltered encampment is a threat to their safety, then, all bets are off. Everything's an emergency. And so, we really have to have faith in our systems as, a state agency that has their protocols, and we have our experts that are landscape maintenance supervisors and superintendents, and they're the ones that can assess, what's a priority, when will this be addressed, especially in this time when they're not actually doing the work. This has to be submitted for a hazmat contractor to address it. And so, that's why we're saying partnership is really vital at this time. If people can't be moved, this is their house. This is their shelter. So to tell Caltrans, you need to do something about human life existing on your right of way. We're partnering with people that could possibly bring some semblance of services to these people that are in great need of a place to go. Medical services, thank you for sharing that, doctors. But what we're doing is we're doing what is best for those unsheltered individuals, because we know shuffling them around is not part of the solution. We could tell them to go, but where do they go? They go to the city streets. They go to the next county. We can't do that. Not during this time.
So
just to be clear, oh, sorry.
This is Deborah. So when we talk about priorities, we think about, so in Caltrans, one of the most dangerous jobs that you can do is work on the side of the freeway. That's by far a realization. At any moment, a truck or vehicle can come and drive off the roadway just because they're trying to evade an accident. So the way that we're prioritizing is bridge cells are number one. We've had numerous fatalities of the unsheltered from being inside that confined space. The timbers that are left in there are called false work. And a lot of times they're treated with chemicals. And so when they erupt, it's a toxic fume. We've also had, they will burn propane inside the bridge cell. There's not ventilation in there. It's a confined space. So it eats up all the oxygen, and all there is carbon monoxide left. And we've come across bodies that have been there for quite some time. So that's our number one thing, is to get them out of the bridge cells. Also, because if they do start that timber on fire, you're more than likely going to have to shut the bridge down, and it's going to need repairs, and we can't have that happen. And then right on the back of that is the electrical issue. We don't want to see anybody get electrocuted. And then we have the clear recovery zone. And a lot of people don't know about the clear recovery zone, but everything that's a fixed object within 30 feet of the travelway has to have a guardrail barrier around it to protect it. And we call that the clear recovery zone. It's an area where people have, when they're traveling at 65, the road is designed to give them a little space to correct and put their car back on the road. And so that clear recovery zone is another area that we're targeting. But that falls within categories because when you get off the off-ramp, they're certainly within the clear recovery, but that's not the same as being up on the main line at 60, 80 miles an hour where cars run off the road. So there's levels within the levels for priority. And then there's there's all the other encampments that are on the backside of walls and stuff like that, which are a relative low priority because their safety's not inhibited yet by our type of priority, but it's still, we have so many, we have to start somewhere. And so that's kind of how we've started. Hope that answers your question.
Great. If there are, if it doesn't answer your question, Matthew, and if there are any other questions, what I'm going to just request, because we're about 15 minutes behind on the agenda, is China put her information in the chat box. You know, just have try to have a conversation offline with her, Deborah, if there's any more specific questions. Thank you both for kind of getting in the weeds there about how you guys are working within this area. I appreciate it. Okay, I am next. I'm going to go super fast so that we can get to Gabby. At our, I'll just give a quick little background. At our meeting, our last meeting, we were presenting the City of Redondo Beach about our enhanced response pilot project and homeless court. And that same day, we were also had a presentation from Pallet Shelter, based out of Washington State. When we got off that meeting, City Attorney Webb and I had a discussion and related to Pallet and reached out to them right away. As a result of that, we've actually moved pretty fast and with unanimous council direction, decided to explore whether or not we could create a temporary transitional shelter site in Redondo Beach using Pallet as a provider. That went into a study phase. Staff, we directed staff to look at just city sites that we possibly could have available and that could work. We were back to council within about a month, and at the end of that very long 5-hour discussion, did ultimately decide unanimously to create a temporary transitional shelter program for 13 months at one or two locations in Redondo Beach. We are going to be purchasing we will have 16 pallet shelters delivered. One of those will be used for programmatic elements, and the other 15 will be used for individuals. Clearly, you can house, for those of you who are here at that discussion, you can house up to 4 individuals in one of those units. We'll just be housing 1 individual in each unit as a result of COVID. And the program will work in tandem with our enhanced response pilot project. Homeless Court also work to deal with some of the individuals that are coming back from Project Roomkey. So right now the program has been approved. We do have funding sources, mainly from the federal government for COVID relief, CARES Act relief, through our CDBG program. The county is also designating money related to their CARES program, and Supervisor Hahn is designating some of her individual department monies to us as well to make this happen. Ideally, we're in the middle of, I don't think I've ever seen anything move so quickly in Redondo Beach. But ideally, I think our 24/7 wraparound services may potentially be provided through Shari and her team at Harbor Interfaith. That remains to be seen, I guess, because everything is in the works. We have a lot of work to do because the CARES Act monies have to be employed before December 30th, which means we technically need to have somebody living on the site by the end of the year to actually to make it work. So we're moving fast on a variety of levels here. I will just say this without going into much more detail. There's been a lot of pushback, of course, from residents throughout our city and through some of our sister cities that are on this call here. And I just want to reiterate something that that Councilmember Buscaino said probably 2 or 3 years ago when we were starting this program, right? And we in Spot 8 are in this fight together, right? And so one of the things I hear from my residents is, well, why don't you just put them in Torrance? Why don't you just put them in Manhattan Beach? Why don't you just put them in Wilmington or Harbor City? And the simple fact of the matter is, and what I try to explain to my residents, and as most of you who are providers here know, we have unhoused individuals in every jurisdiction. So what we really need, and the whole point of this group coming together every 2 months to learn about, programs and exciting things that are out there to help us be proactive in the fight, is that we need everybody to step up and do something. 15 units is not a lot. Let's face it. It is a far cry from what, Councilmember Buscaino is doing with a bridge housing and Shari's doing in San Pedro, and what his plans are to do, in general in his district. We really need everybody to step. If we're all doing this or something similar to this, then our residents can't really say, well, we should send them to Torrance, because Torrance will have their own program. If we're each working with our unhoused individuals in our own cities, I think we will, in a more effective and efficient manner, be able to transition them through services and eventually into some type of permanent supportive housing. Or we can just sit back and watch, other cities do stuff and just hope that, the problem does not become exacerbated in our own city. So that's my plea to all my sister cities here on the meeting today. Please, we could use your help and assistance in coming up with similar programs in your cities. I know Supervisor Hahn would be extremely supportive and helpful in trying to make that happen as well. If there are any questions related to what we're doing in Redondo Beach, feel free to just contact me anytime offline, because I want to make sure we get through the additional things on the agenda today. So with that, why don't we move on to Gabby? You're going to talk about your pallet shelter interim housing.
Well, first and foremost, thank you, Councilmember Horvath. I know that Councilmember Buscaino, as well as Jacob, both reached out to you to, one, commend you on your leadership, and two, commend the city of Redondo Beach. I know it's not easy. I've been doing this now for 2.5 years, and I probably was the most hated individual in CD15, but it's really good work that we're doing. And so I personally want to thank you from the bottom of my heart, because it makes our jobs easier. And you're exactly right. If everyone took responsibility and accountability for those unsheltered living in their communities, we would all be in a far better place right now. So thank you so much. With that, I am going to share my screen, and I am going to start my presentation on CD15's housing solutions. And so to start with, I'd like to just begin that since 2017, or really since 2012, we've had a number of initiatives, lawsuits, and points in time in the city of Los Angeles where we have decided as a council to take very aggressive steps to address homelessness, both from the housing perspective as well as a services perspective. And we have a number of initiatives that are temporary. Some are, transitional and others are permanent. And so this just gives you a glimpse into what CD15 is doing. We encompass the communities, obviously, of San Pedro all the way to Watts on the northern end. And if you guys have any questions, again, feel free to email me or call me afterwards, but I'm going to try to skim through this as fast as possible because we only have 20 minutes. So since 2007, the city of Los Angeles passed Measure HHH, which would ideally give us $1.2 billion to build units. However, because units are not built overnight, we had to find an interim solution to housing. And so Mayor Garcetti, along with the council, came up with a number of initiatives that we could do that with. On top of that, we also have Measure H through LA County to supplement the work of HHH through the means of, social services that are needed both on the street as well as in permanent supportive housing units that we built. We've also seen a significant influx of state and federal funding because of COVID. So what we're seeing now is something that we would have probably seen had we declared a state of emergency within the state of California or the city of Los Angeles. So we're very grateful for the FEMA funding. We're very grateful for the state funding, and obviously the city funding and the county funding. We've also seen lawsuits like the Garcia lawsuit, the LA Alliance lawsuit, as well as the Judge Carter negotiations that we're currently dealing with right now, and we're at the table. And Councilmember Buscaino is one of those members with Council President Neri Martinez, trying to get to a level where we have every council district provide at least 60% of the total number of people experiencing homelessness in their district shelter for these individuals. So if we can get to 60% of beds, then we can all move to a level of, I think, compromise that would be both comfortable with property owners, business owners, and individuals that are in need of our services on the street. So obviously the goal for everyone is to improve the lives of those living on the streets, moving people from the street into a home. And it's been a very, very long journey, a journey that was started with our service providers many years ago, decades ago, really. And we are now working in probably a much more collaborative effort than we've ever seen in past decades. Our SPA 8 providers include Harbor Interfaith, who's our lead CES provider, LASA, People Assisting the Homeless, Mental Health of America, LA County Department of Mental Health. And our SPA 6 partners include HOPIX, WLCAC, LASA, and St. Joseph's. And these are our formal partners, but we obviously have church partners, we have volunteer groups, and then we also have our CD15 working group, who is comprised of advocates from all over CD15, including all the neighborhood councils. So the CD15 2000 count revealed that we had over 2,200 people experiencing homelessness. 30% of those were in makeshift shelters. Another 30% were in campers and RVs. And if you're familiar with 8512, is it 8512? Wait. There's so many ordinances. The one where we pretty much would allow folks to sleep in their vehicles. So when the state overturned our policy where we weren't allowing folks to sleep in vehicles, we had to create a map where folks could sleep in vehicles. And it was determined by zoning. And the council voted that it would be most appropriate for folks to be able to sleep in their vehicles overnight in non-residential areas and in areas where it would be more appropriate. Industrial areas and some commercial areas as well in the evening. Unfortunately speaking, that lies very heavily in CD15. 40% of our landscape is zoned industrial. Therefore, we did have a significant increase of folks sleeping in their vehicles come to our area. The point and count for 2020, obviously it did go up. There was a 12.7 rise for LA County, and the city of Los Angeles saw a 14.2 rise. And for CD15, there was a decrease, but only because there was a miscount in 2019, but we thought that we had seen an increase as well. So it went from 2,629 to 2,264. Our goal is to build a safe shelter system that can support at least 60% of the unsheltered population at any given time. In 2020, that would translate to a target of 1,400 individuals. And this presentation will show you how we're trying to meet that goal. So the way that we're doing it is we want to make sure that it's a network that is both responsive and reflective of the unique characteristics of the district's homeless population. So with that said, because we have individuals both in makeshift shelters, we have them in tents, we have some just lying on the street, we have some in vehicles, RVs, this will reflect the needs of those. So what we've offered, or what we've actually currently have open right now, is the Harbor Area Navigation Center. Is a storage facility. We were the first in the city to initiate that, and our location is by the police department, the Harbor Police Department, and it holds 165 units for folks to come and store their items. It's up to 60 gallons, and we currently, I believe, have only 10 bins available because those services have already been connected with folks that are experiencing homelessness in the harbor. We have a safe parking program in the northern part of the district. It's at the WLCAC, and it's about, for I believe, 40 vehicles. Project Room Key, it's an emergency shelter as a way to have folks shelter in place, the most vulnerable, 65 and over, as well as folks with pre-existing conditions. A bridge home shelter, which you're familiar with, rapid rehousing, permanent supportive housing, and affordable housing. The Navigation Center, as I mentioned, storage capacity, 168 bins, and the service provider for that one is Volunteers of America. In addition to servicing the Navigation Center, Volunteers of America is also responsible for doing outreach of services in our district. So we did gain them as a service provider. And the way that their services are requested is either they do voluntary outreach at all of our encampments, where service requests are provided through 311. We also dispatch them to encampments that we either see, that LAPD sees, or that neighborhood residents see, and then contact us through the office. And our service provider is Volunteers of America, as I mentioned. The safe parking, it is in the northern part of the district, and it is operated by WLCAC in Watts. It's 40 spaces, and it's from dusk till dawn model. And they would then connect folks to restrooms, showers, as well as services, and sometimes meal programs that WLCAC has available. We are expanding this to encompass approximately 125 vehicles total. And the one site that we're rolling out is in San Pedro. It's actually at our Beacon building, our municipal building parking lot. And that one will be for 25 vehicles. We're looking at another site in Wilmington for vehicles. It's a Caltrans park and ride lot. We're facing a little bit of pushback from Caltrans only because of the federal highway funding. And we're looking at a site in the Harbor Gateway for vehicles. It's a HACLA property, and one in another part of another Caltrans park and ride lot in Harbor Gateway North. So the one in Harbor Gateway, that one we are actually in the process of putting together the lease. It'll be between between HACLA, which is a property owner, and WLCAC, who currently operates the other safe parking on the northern side. It's a publicly owned property, and it's in a light industrial area, and it's perfect because they close their offices right by exactly by 5. Everyone has exited the lot, so that means that we can open the safe parking pretty early, between 5:30 and 6, and folks would be out by 7. It's for 25 vehicles, and again, it's only for overnight. The San Pedro Municipal Parking Lot is another one. It's city owned. It's in a regionally commercial zoning. It's fully fenced off. It's very secure. And there's near services. Harbor Interfaith is next door. We also have a shelter next door. And it's pretty well, I would say, secured based on the fact that we also have security across the street in our building. Another estimated capacity is 25 vehicles. And we are looking forward to having a conversation between this service provider, which will be Volunteers of America, WLCAC, as well as Harbor Interfaith, to get a better understanding of where the folks are in their vehicles. Perhaps we can designate this one for families, the other one for singles, or this one for cars, the other one for RV, since it's much larger. And we're in the process of doing that now. And this one is in the same process train where we are formalizing the leasing agreement between the service provider and the City of LA, which is GSD, and it'll be a 3-year funded program minimum. The partnerships for the Caltrans lot, obviously it'll be Caltrans. We're waiting for federal transportation approval. And there's one on Figueroa Street. It's PCH and Figueroa. And then the other one is Avalon and 116th Street, Place. And it's Harbor Gateway North, bordering Watts. Our next initiative, this one is open. You're all pretty familiar with these. We started this in 2018, the conversation, and construction lasted about, I would say about 12 months to 15 months, 6 months. However, getting the land acquisition was very difficult in Pedro because we had to go through federal highway approval. And then in Wilmington, the lot belonged to ILWU. It had to be transferred to the city. And in Watts, the lot belonged to HACLA and it had to be leased out to the city. So our Watts is our Salvation Army provider. Wilmington, we have US Vets, and in San Pedro, we have Harbor Interfaith, and it's 100 beds each. So they're 300 beds in total. And Watts is at capacity. Harbor Interfaith is at capacity based on the DPH guidelines, and we are building Wilmington's to capacity. We had some issues with that one, unfortunately. We did have a COVID outbreak, and the site was quarantined for a month, so it discouraged a lot of folks, and they went back to the streets. And after that, we had a bed bug outbreak. And so, when you tie that with COVID on the streets, it's been barriers that we've had to go through, but we recently had a meeting with LASA as well as other individuals, and we're very hopeful that moving forward, we're going to be able to bring folks back into the site, reinstill that trust into our services, and make sure that we keep them there moving forward. Our Bridge Home 2.0, as we would call it, is the pallet shelter that the council member was referring to, and it's pretty much using trailers or individual pop shelters, some kind of sprung structure to have a 3 to 5 year time span. So we're currently evaluating sites for one additional site, and it's at the Harbor Sports Complex if you're familiar with it, it's on Figueroa Place, and it's right across the street from Harbor College. So it'll be a pallet shelter facility with at least 75 units, offering safe shelter to at least 75 to 80. We were hoping that it would be up to 100 individuals. As the council member mentioned, we can put up to 2 individuals in the ones that we were looking at. However, because of COVID, unless these individuals are directly related or are in a companionship already on the streets, it'll be very difficult to team them up with a complete stranger. So we had to bring that number down to 75 and 80, which really affected our overall total number. Project Room Key, you're all very familiar with it. Thanks to FEMA funding, we were able to get one site in San Pedro. Councilmember Buscaino and his staff actually were responsible for securing this contract in San Pedro, 100 beds at capacity, and our operator is Salvation Army. I think that through the success of Project Room Key and trying to get a better understanding of how we transition these folks into a more long-term place, we're looking at the state of California's Home Key program, which is using state dollars to purchase hotels and convert them into permanent supportive housing for individuals. So we have 2 sites that are being acquired by the end of this month. The Harbor Gateway side is at the Travel Lodge, and it's 40 units. And there's one in Harbor City. It's right outside of our jurisdiction. It's actually in an unincorporated LA County, but it's right adjacent to us, and it has 57 units. And this can sometimes house up to 2 individuals per unit if they're couples, or if they're singles, 1 person per unit. Permanent supportive housing. This is the money that we've all obviously loved. It's permanent. It's provided with a service provider on site to provide these services to folks to ensure that their stay at these facilities is long-term. We actually have a project. I think it's actually this picture. This one is in the Gateway off of Redondo Beach, and unfortunately, because it was built prior to our commitment, it didn't necessarily go into the overall count, but we're still very much proud of it. The 13 projects that I am referring to are either in our pipeline, under construction, or will be under construction within the next 2 years. And it's 13 projects, 645 units. 3 of those are under construction. So that means 1 to 3 months for that to be fulfilled. And that's 144 units. 2 projects are close to construction, 3 to 6 months. Another 3 projects are 173 units, and they're currently going through the planning and the permitting process. And an additional 5 are in pre-development phase. So that means that they're about 9 months out from completion. And depending on the developer, depending on the construction phase itself, if there are 0 interruptions, these projects can go from breaking ground to ribbon cutting as quickly as 15 to 18 months, depending on the size of them. These are the projects. So we actually made a 222 commitment a really long time ago, along with other council members on the city of LA. And we are very proud to know that we will be at 645 once these are constructed, plus an additional 13 for manager units. And these are the projects, the addresses, the communities that they're in, the number of units, as well as the developer or the program that will be running them. Additionally, sorry, one more. We're also looking into affordable housing. As you know, we have, if you don't know, we have the largest number of government affordable housing west of the Mississippi. We have 6 projects, 6 developments in Watts. We have 4 large ones in Wilmington. We have 1 large one in Harbor City and Rancho San Pedro in San Pedro. And so the Jordan Downs was expanded. And so we were able to add an additional 398 units to that one by building up. And so there's 398 currently in the pipeline that will be under the construction within a year. And then we're also working with Hopix in SPA 6 to identify 200 beds that'll be secured through the rehousing organization. So that is looking at leasing properties that are currently on the market and putting them back to repurpose to house individuals that are experiencing homelessness through shared housing or other ways. And then the housing with community benefits. These are our market rate housing. As you know, we say yes to all types of housing. And when we can build market rate and get affordable as an exchange, it's even better because it costs the city 0 taxpayer dollars. So we have 12 projects bringing a total of 1,150 new housing units, and of which 140 of those will be restricted to affordable rents. And that is done through the transit-oriented communities and density bonus. And so we're very excited about that as well. And so 77 will be low income units, 58 will be very low income units, and 5 is extremely low income units. And so these are the summary of our numbers. So we're looking at 1,183 units or beds, I should say, or spaces that we're providing to folks in the coming years. And we're very confident that, in the coming years, we will find a much more better strategy to work with individuals that are living in RVs. And we also need a better tracking system for identifying rapid rehousing and really being able to identify where the beds are when folks are contacted. And let's say LAPD or an ambulance or an LAFD wants to find a bed for them that night, being able to identify where these folks can go. Huge debt of gratitude to all of our working partners that are listed here. And that is our plan.
Fantastic. Thanks, Gabby. I'm going to, going right off your last statement there with rapid rehousing and stuff, I'm going to jump ahead and not take questions if that's okay. So if anybody has questions for Gabby, please contact her offline. Gabby, if you put your contact information in the chat room. But let's jump ahead quickly to Grace and Jackie to talk about home share, because that is another strategy that we're working on here that I think goes hand in hand with like rapid rehousing.
Yeah, I want to make sure that Grace does home share, but we also have to make sure that Janet Turner.
I'm gonna jump to Janet at the end because she has an announcement, I would hope. So,
okay. Yeah. Okay, Grace.
Okay, let me flip to. I wasn't ready yet.
Okay, while Grace is flipping, well, I just want to mention one thing, which is not exactly on point, but the Council of Governments has built a fiber network ring, and we're extremely excited. It's connecting all of our city halls. It's going to allow us to provide better services to constituents. And we're having a celebration of that ring at 10:30 on November 17th. It's a Zoom celebration. So if you're interested, please check our website out and we hope you'll join us.
Okay, so I'm ready now. And also I did want to mention, because I knew this was a packed meeting today, and I apologize for that, just that there was so much great, exciting information that was going on before the end of the year, because we're not going to meet again until the start of the new year. So I apologize for that. But one of the things that the COG is really excited about is we have launched our Home Share South Bay. And we launched it on October 15th. And we are partnering with Silvernest, which is an online platform. And we're matching homeowners in the South Bay who have an extra room for rent and matching them with home seekers. And then we're really focusing our efforts on home seekers who are on the verge of homelessness or recently homeless. They may be sleeping in their vehicles. They may be sleeping on friends and neighbors' couches, but we're really looking for those individuals who have low acuity scores, because we want to make, these are folks that may still be employed, but they may have just lost their housing for whatever reason. So those are the folks, the home seekers that we're looking for. But right now our efforts are really moving towards looking for homeowners so that we can build that base. And and many of the homeowners that are here in the South Bay, they may have lived in their home for a long time and are what is considered house rich, cash poor. And so with a home sharing program, they could receive rent to assist with their living. They could also reduce the rent in exchange for household services, or even transportation issues. And companionship seems to be a big area, especially with older adults. There are gads of studies out there that really talk about isolation can lead to depression and all kinds of, a whole host of health related issues. And a lot of it is if we can get companionship in for some of these older adults, and at the same time, they may be feeling very altruistic by assisting somebody else who may be on the verge of homelessness, and just trying to make that match together. So right now we've been, and actually, David, can you put on our, upload our landing page? And then I also see, and these are for long-term, the goal is to make these as long-term rental agreements. So I know that I'm seeing here a note from Roberto Chavez that with the city of Inglewood that will comply with short-term leases, but it's not an Airbnb situation. These are for long-term leases with our goal of making them long-term leases. So right now we've been reaching out to our city staff to help get the word out to the residents, and we've developed some flyers and some other materials. So we're asking for our city friends to get that information up on their websites. Shout out to Inglewood, because I know they've already got it on their website. And we're now sending out information that can go out social media wide, or having flyers that can go out with, like, again, Inglewood is a great example. They're going to put flyers as they deliver their meals to some of their senior residents. So we're excited about this program. The way to start is to go to our landing page. Whether you're a home seeker or a homeowner, you fill out your profile. There's no cost to do your profile. There is a fee that's associated for homeowners once a match has been made. And that's where our pilot project comes in, is we have limited funding to be able to pay for 6 months for the membership, the Silvernest membership. And through that membership, you're able to connect with individuals. There's also insurance that's available, up to $100,000 for homeowners and $10,000 for property for the home seekers as well, or the new tenants as they come in. So anyway, I know that's really quickly in the overall of what we're doing. But I also wanted to mention that we are, as people complete their profiles online, then an email comes back to them from Silvernest with the COGS information, so that we are there to try to help them through the process and then connect them with any services that may be available that they may need. So we're really, really hoping that this is a very rich and robust program as we move forward.
Awesome. Jackie, did you want to add anything or?
No, I just think that we're very proud of it, and please help us out here.
And then the only other thing I wanted to mention for our report, and this is from LASA, because all of our city partners should have received a request to participate in the Homeless Count 21 surveys. And all those surveys are due this Friday, November 6th. And then next Thursday, November 12th, from 12 to 1, LASA is holding a meeting with the municipalities to really look at those different surveys and really figure out how to move forward with the homeless count for 2021. So I just want to remind everybody that if you haven't already completed your survey, then please do so, and please also be available for the meeting next Thursday, November 12th.
I did mine this morning. It took all of 2 minutes. So
okay. Great.
That easy. Okay, so we're going to wrap up this meeting. I'm going to kick it off over to Janet Turner from Ted Lieu's office, who, if you haven't seen the news, hopefully will share one of the most recent introductions into legislation by Congressman Lieu.
Yes, hello and good afternoon, everyone. I know everyone's eager to get off and get going for the rest of the day. Congressman Lieu introduced HR 8674. It's called the Prevent Homelessness Act, and it is designed to help stop people from becoming homeless in the first place. The bill creates a $500 million housing stabilization fund to help struggling Americans who may be just 1 month away from losing their home or one utility bill away from having their lights shut off. So it's primarily for low-income families. It's to meet housing-related obligations, such as rent, utilities, possibly legal services, short-term payments, and it also does include counseling as well. The congressman feels that right now the risk of homelessness is incredibly great, considering how many Americans are overwhelmed by the pandemic. And he's hoping that this will be one way that can prevent some people from falling into homelessness. So look for that in the coming year.
Fantastic. All right, everyone. I apologize that we went a little bit over. As Grace said, our next meeting will be in the new year. Hopefully the new year will be a little bit better than this year, but we will still be meeting virtually, at least for the next 6 months is my prediction. With that said, if anybody does have questions or whatnot, please just reach out directly to Grace. You can download the chat file to your desktop. It has phone numbers for everyone. Well, if you can't download it, just do a copy and paste, or Grace will also be able to send out any of that information as well. So thanks, everyone. Have a safe week and a happy holiday season. And we'll see you all soon. Take care.
Thank you.